In Class 2, we will be discussing pain, nutrition, culture, and violence. There is a second PowerPoint on domestic violence. Pain is the most commonly reported problem in the elderly population. It's the number one chronic disease reported. Osteoarthritis accounts for pain in about 50% of elders. Pain is under-recognized and undertreated. Individuals with pain account for a large portion of the workforce that stays out of work because of pain. There is a loss of work, loss of wages, decreased physical functioning. People report significant sleep disturbances, and pain results for many people in anxiety and depression. The Joint Commission has created the fifth vital sign, which is pain. This was launched in an initiative by the VA hospitals in 1999. Today, pain assessment is an integral part of all patient assessments in all healthcare facilities. The Joint Commission standard for pain requires that all healthcare organizations recognize the right of patients to appropriate assessment and management of pain, screen patients for pain during their initial assessment and when clinically required during ongoing periodic reassessments, and educate patients suffering from pain and their families about options for pain management. Margot McCaffrey is a leading nurse scientist who has written extensively about pain and the pain experience. She says pain is uniquely experienced by each person, and her classic definition is, pain is whatever the patient says it is. Pain does not simply correlate with physical pathology, but is a subjective experience, with pathology only a part of the experience. It's important to recognize that even a neonate can experience pain, so we must consider the developmental level of our client when we think about what that client is experiencing. Also, cultural expression varies greatly. It's really important to understand that different cultures have different beliefs. What is your personal nationality? How do you express pain? How do the people around you express pain? How does this differ from other people that you know? There are various types of pain. Acute pain is related to a specific injury. It is short-term, it is self-limiting, it follows a predictable trajectory or track, and it dissipates or disappears after the injury heals. This type of pain is specifically related to a very specific injury. Surgery, for example, is an example of a person with acute pain. After the surgical procedure heals, then their pain goes away. Chronic pain, or non-malignant pain, is associated with a specific cause, but it continues for a longer period of time, usually 6 months or longer. This pain does not stop when the injury heals. We see this in individuals with chronic back injuries and other types of chronic injuries. Cancer pain can be related to chronic, ongoing, unremitting pain, often due to compression or damage to the nerves, the meninges, following surgical procedures, chemotherapy, radiation, or tumor growth that infiltrates and causes pressure on nerve endings, resulting in pain. Pain elicits a stress response in an individual. Recall from pathophysiology, or your anatomy and physiology classes, the cellular stress response. Remember fight or flight. The body produces epinephrine or adrenaline, and this causes the person to experience a number of things, both psychologically and physiologically. Pain can cause anxiety, fear, hopelessness, sleeplessness, and even thoughts of suicide. We've all heard of the movement in this country towards physician-assisted suicide, and one of the reasons people seek this is intractable pain, from which they cannot escape, from which they have received no relief. When a person experiences pain, they focus on pain. The experience of pain differs in different cultures. A person may cry or moan, frown, or facial grimace, yet other people may not experience or demonstrate to you any physiological outward side of pain. They may be stoic with a grim face, but no outward experience of pain. Pain response will decrease gastric and intestinal motility, decrease the urinary output, depression of immune responses, even decrease cognitive function. A person cannot concentrate when they're experiencing pain. The stress response increases the heart rate, increases the blood pressure, increases the respiratory rate, may increase sputum production. The stress response also increases blood glucose. A person who is diabetic may experience hypoglycemia. Protein catabolism and pain in an area can cause significant muscle spasm, which contracts the muscles and only contributes to the pain. There can be many prejudices and biases related to how nurses perceive a patient's self-reporting of pain. This can lead to inaccurate or poor pain assessment. For example, I recently observed a patient admitted to the emergency room at a local hospital who was an elderly man and screaming in pain, writhing, screaming, yelling at the top of his lungs. This affected everyone in the emergency room in a similar way. Does this man have excruciating, agonizing pain? He was being admitted with the diagnosis of a kidney stone. As we know, kidney stones can produce some of the worst pain that people experience. On the other hand, think about the patient who is admitted with the diagnosis of a kidney stone, who doesn't scream, doesn't yell, doesn't writhe in pain. Does that person's pain, is it less than the first individual? We really don't know. Pain is, as McCaffrey says, anything the patient tells you. So we have to try to avoid our own personal biases when we observe people in pain. As with any patient interview, it's important to establish an appropriate environment to collect the data. Always maintain privacy. Often this is difficult to do in double bed rooms, or for example, if you're in a hallway in an emergency room. But it's important to do one's best to maintain that privacy. Ask questions in an open-ended format and listen carefully to the client's description. Quote the person's exact words. For example, the classic description of a person having a heart attack, particularly a male, is, "My chest felt like it was caught in a vice," or "It felt like an elephant standing on my chest." Do not put words in the patient's mouth. Have the patient describe in their words the pain experience. When assessing a client's pain, always ask specific questions. There are various mnemonics for helping us remember the questions to ask, but we want to know, how severe is the pain? Evaluate the behavior of the client and their physiological changes. Make sure you get the patient involved. Take the cause of the pain into account. We know that renal pain, kidney pain, spastic uritis because of a kidney stone is an excruciating pain. Chest pain can be a devastating experience for a client. How does the pain limit the person's function and activities? This is particularly true for chronic pain as well as acute pain. How do you behave when you're in pain? What would others know? How would they know that you're in pain? What are the concerns about the pain? Accept the patient's rating of the pain. Remember, one of the mnemonics that is common is for us to remember the onset, location, duration, character, aggravating and alleviating symptoms, radiation, and timing. This mnemonic old cart is used in some textbooks. Others use the PQRST mnemonic for pain. Whatever mnemonic is easiest for you to remember is the one you should use. We try to collect objective data regarding the person's pain experience. By observing an individual, we note their facial expressions, grimacing, posture, positioning. Are they crying out in pain? Are they writhing? All these are observable pieces of data. We know that pain elicits the stress response, so we assess vital signs. Pain will cause an increase in the heart rate, an increase in the respiratory rate, and an increase in blood pressure. In an attempt to standardize pain evaluation, we use numerous pain assessment tools. There are a number of ones that are out there. You probably have experience with at least one in your clinical practice. The verbal descriptor scale, the Wong-Baker scale, which is used in pediatrics, a numerical rating scale, or the visual analog scale, which is a line, and we will look at these now. This is the numeric pain intensity scale. It's probably one of the most common. It rates a person's pain on 0 from no pain to 10, the worst possible pain a person can experience. 5 is considered moderate pain. You may have experienced the use of this scale yourself, either with patients or on a personal level. Moderate pain sits right in the middle, 5, 6, 7, and a person attempts to describe their pain on a scale of 1 to 10. This temperature type scale is a slightly different scale. Note, almost each number has a description attached to it. From 0, no pain or none, up to 10 being agonizing and the worst pain possible. Note that 6, severe pain on the scale, is described as dreadful, moderate pain, uncomfortable, and then mild pain, the 2, is an annoying pain. The FACES scale is a bit different in that this can be used with children. The smiley scale on the left-hand side is no pain and is described as no hurt. The 10 on the right-hand side is the sad face crying, which is the worst pain possible and hurts the worst. The scale, the faces go from the smiley face to the very sad face, and this scale is useful in children to determine the pain that they are experiencing. This is the nutritional recommendations from the U.S. government. The recommendations changed several years ago from the food pyramid, which had been around for a while, but had no acceptance in the public, to a much clearer depiction of the recommendations, known now as My Plate. The colors indicate that half of the plate should be comprised of fruits and vegetables, proteins less than grains, with dairy accounting for a smaller portion.